Module 3, Emergency Medication Administration. KRS 158838 permits the delegation of glucagon, diastat, and epinephrine to be administered in a possible life-threatening event. This regulation also requires that each school district have at least one school employee who meets KRS 156502 requirements and to be on duty during the school day to administer emergency medications. Bullitt County interprets this to mean any school-affiliated activity. General guidelines for all emergency medications include that they must be available for quick access for those that are trained to administer. However, we need to make sure they are kept in a secure location and should never be left on a bus. All expiration dates will be checked monthly, and that we will give the parents 1 month advance notice of this expiration per statute. Please note these dates on arrival to school and periodically recheck them. Whenever an emergency medication is given, someone must call 911. Give ownership to this person of the task. Do not say, "Someone call 911," but instead call that person by name or give describing characteristics so that they know that the job is theirs. This person should also meet the medical response team at the entry point of school and escort them back to the student. The EMS team may or may not take the injector from you, but please make every effort to send it with them. If you are a coach and you have an athlete that has an inhaler or an emergency medication, it is recommended that you look at the medication from time to time and know where that medication is kept. Make sure the medication is not expired and that the equipment needed is available in case of an emergency. Have verbal agreements with your athletes. Some coaches have told me that they use the buddy system. The child with the emergency medication will always place their gym bag next to the buddy so that it can quickly become identified. Remember that students that self-carry might not have their medications always with them. If you find that to be true, please contact health services and the parent. Be prepared. There are two types of diabetes. Type 1 is not related to eating habits, and this is the majority of what BCPS has in our district. Their body does not make insulin, which is necessary for the cells in the body to have energy. The cause of type 1 is unknown, but it may be viral in nature. Type 1 diabetes must be managed the entire school day, and time must be allotted to meet their needs. Type 2 is linked to genetics. Diabetes is a chronic progressive metabolic disorder that can cause a child to develop long-term complications of the eyes, kidneys, feet, and circulation. If blood sugars are not kept in a specific range, these complications can start developing quickly. There are abnormalities in breaking down the carbs, fats, and proteins that we eat, leading to hyperglycemia or high blood sugar. So let's talk further about diabetes. In people without diabetes, the sugar will enter the cells for energy, and the blood sugar levels remain in a stable range. Insulin is the key that opens the doors to the cells and lets the cells use the sugar for energy and activity. They have a normal working key and normal lock. There are some major differences between type 1 and type 2 diabetes. In type 1, the body does not make enough insulin, therefore no keys. So the cell doors cannot open for the blood sugar to enter and be used for energy and activity. Insulin is a necessity to survive, so individuals with diabetes have to have their insulin or keys provided through another route. Type 2, insulin can and is often used to manage, but lifestyle changes of meal plan, activity level, or oral medications are used. Oftentimes, their keys just do not fit. This picture is of a young girl who had type 1 diabetes but was not under treatment with insulin. In the early 1900s, the diagnosis of diabetes was a death sentence to that child. Insulin was not available for human use until 1922, and before then, the only treatment was diet restrictions that were so severe that children sometimes only got 400 calories a day. Thus, many of the children starved to death. Then as now, diet is the key component in maintaining a stable glucose level. This is the same child 6 weeks later after being started on insulin. Hypoglycemia or low blood sugar is usually considered for a reading of less than 70 or 80. Each student with diabetes who requires insulin should have a diabetes healthcare plan. Because hypoglycemia symptoms may range from mild to severe, the student's licensed healthcare provider will write a plan of treatment describing how to treat the symptoms based on the severity. Administering glucagon is usually the last type of treatment for an extremely low blood sugar, and the student is unable to eat or drink liquids. If the symptoms of hypoglycemia are detected early, other forms of treatments are usually prescribed to be given first. Often just checking a blood sugar before and after physical activity can prevent a low reading. Never send a child to the office alone, especially if they are showing symptoms of low blood sugar. Hypoglycemia is the most frequent complication for students with diabetes who require insulin. Nurses will administer a calculated insulin dose, but we cannot take into account what else is going on in the body, such as illness, stress, or hormones. These may not be all the causes for a student with diabetes to experience hypoglycemia. Student health plan or emergency action plan may identify others. Student's health plan or package should detail how to treat hypoglycemia, mild to moderate or severe. Glucagon may be prescribed to be administered when the student is unable to take food or liquid by mouth. For extracurricular activities, a change in the student's normal activity or a delay in eating, such as a game is delayed or goes into overtime, could affect blood sugar levels. To prevent a dangerously low blood sugar, check blood sugar's level frequently and carry snacks. For a blood sugar reading less than 70 or 80, a quick recovery plan is called the Rule of 15. You will have a student eat or drink fast-acting carbohydrates. Limit to 15 carbs to prevent a high reading later. Examples would include 3 to 4 glucose tablets, 4 ounces of a juice or regular soft drink, or a fun-sized pack of Skittles. Read labels and make certain you see serving size. Check blood glucose level 15 minutes after treatment. Have someone call the school nurse if a second treatment of quick-acting carbohydrates is necessary. Repeat treatment of 15 grams of fast-acting carbohydrates if blood glucose level remains low, and recheck at another 15 minutes. If symptoms continue or blood glucose levels do not increase, have someone call the parent or guardian, or if needed, have someone call 911. It is important to provide the student with a snack such as peanut butter, crackers, or a half a sandwich or a meal following the treatment for hypoglycemia to stabilize the blood sugars. Glucagon is available to people with diabetes for when they're experiencing a very low blood sugar. It is the responsibility of the parent and guardian to provide the glucagon. The amount of glucagon to be administered is located on the label. It is weight-based. For an early elementary student, you will give 1/2 to 1 milligram. For a middle school student and up, it will be 1 milligram. Always follow with a snack once the child is awake and talking. Be prepared for the child to vomit as the blood sugar rises. Keep the child lying on their side. Here are some common signs and symptoms of low blood sugar. Usually the child will have the same symptomatic characteristics when experiencing a low blood sugar. Therefore, if you have a diabetic student in your class, it is always best to ask the parent for what you should watch for. These descriptions should be outlined in your substitute folder. Be prepared for low blood sugar readings, especially when away from school. Make certain that you take a quick-acting sugar and a slow-acting carbohydrate for your diabetic student. You must be prepared for a delay, either getting a meal or returning to school. Ask your parents to provide the food sources. If they are not supplied, contact health services for some additional foods. Child eats lunch at 11:30. She comes to the teacher at 9:45 complaining of feeling or shaking low. What needs to be done? If supplies are kept in the office, then you will send the student there with an escort. Front office will check the blood sugar. If treatment is required, they will give a simple sugar. But the question is, would you give a carbohydrate or would you wait for lunch? In this instance, you would need to give the carbohydrate. Any longer than 30 minutes is too long to wait. Always document that follow-up blood sugar number. If it is not documented, then it appears that it was never done. Repeat all checks in 15-minute intervals. According to KRS 158838, each local public school district is required to have at least one school employee on duty during the entire school day to administer glucagon in an emergency.
Welcome. This glucagon demonstration is for school personnel who are willing to provide care for those students with diabetes who have glucagon prescribed in their diabetes management plan. Glucagon is considered an emergency medication and is to be used in cases of severe hypoglycemia when a student is unconscious or unable to swallow.
In this video, we will be using two different glucagon kits, an actual kit that your student would have, which is red, and a white kit that can be used for training purposes. The difference between these kits is that the white kit is for practice and does not contain an actual needle or medication, whereas the red kit is what you would use in a real-life scenario. We will be focusing on the white kit that you will be using for training.
In the case that you need to administer glucagon, the first thing to remember is to stay calm. Follow the student's emergency action plan and make sure that you are safe. Assess the scene around you. If you are on a school bus, have the driver pull over. If you are at a sporting event, have someone nearby clear a small area and call 911.
If available, put on gloves. Obtain the student's glucagon kit. Based on the student's individualized healthcare plan, you will determine if you will need to administer 1 milligram or half a milligram of glucagon. Remove the flip cap seal from the vial of glucagon and wipe the top with an alcohol wipe if available. Remove the cap from the needle in the kit and pierce the needle into the seal of the vial. Inject the contents of the syringe into the vial. Leaving the needle in the bottle, carefully swirl the contents of the vial until the solution becomes clear. This will take about 10 to 15 seconds.
Carefully holding both the syringe and the bottle, turn the bottle upside down and pull back on the plunger to withdraw either half or all of the glucagon. On the actual syringe, these measurements will be clearly indicated. Make careful note of where the needle is at all times. Holding the vial upright, carefully remove the needle.
Expose the injection site, either the upper outer arm or thigh. Ask for help if needed. Use your needle-free hand to cleanse the area with alcohol if available, while carefully holding the needle in your other hand. Insert the needle into the clean area at a 90-degree angle. Inject the medication.
Carefully remove the needle and place the needle into the red box. Close the box. Place the student on their side to clear their airway as the student may vomit. Update 911 that you have administered the glucagon. If at any point you need a reminder of what to do, there are picture instructions on the inside of the red glucagon kit, as well as a full set of written instructions. Jenny, are you okay? 911, this is Miss Smith from Northwood Elementary School. I have a student with diabetes. She's unconscious and I'm going to prepare to administer glucagon. I'm putting you on speakerphone. I'm going to turn the student on her side. I just administered glucagon, 1 milligram. Make sure to remain with the student after administering glucagon. If they wake up, give them an immediate source of sugar, such as juice. Then follow it up with a snack that has both protein and carbohydrates, such as cheese and crackers or a meat sandwich. You will also want to notify the parents of the student that you have called 911, administered glucagon, and that the student will be going to the hospital. Always remember, in any kind of emergency situation, to remain calm and to keep everyone involved, including yourself, safe. Thank you for watching.
Hyperglycemia or high blood sugar is usually a reading over 200. Some examples of high blood sugars are extreme thirst, frequent urination, drowsiness, or nausea. These children need access to the restroom without penalty. Oral inhalers deliver medication directly to the lungs through the mouth by squeezing the canister or by direct inhalation. The nebulizer produces a fine spray mist by rapidly passing air through a liquid that is inhaled through the mouth. Individualized training will be offered if your student has a nebulizer. Please contact Health Services to set up a training date. We have over 500 inhalers and over 800 asthmatics in our district, so the likelihood of you having an asthmatic in your building or classroom is very high. The average national statistic is that a classroom of 30 students, 1 in 5 will have asthma. In Kentucky, we average 1 in 3. All students with asthma should have an asthma packet on file, and you should know the details of that packet. This paperwork is completed each year and outlines the triggers that might place your student in danger. You must know those triggers. By statute, these children can carry the inhaler on their person as long as the physician has properly completed our paperwork. If you witness a child using an inhaler, please check with the office to make certain an asthma packet is on file. Additionally, this ensures the medication is given as ordered. Here are the steps to administer an inhaler, and this is what you will need to demonstrate when you come for your skills checkoff. Number 1, you'll shake the inhaler, especially if it's been sitting in a drawer for a prolonged period of time. Make sure the canister is firmly positioned. Tilt the student's head slightly backward, maybe even have them stand to increase lung capacity. Ask the student to exhale, then place the mouthpiece between the teeth and close lips around it. Squeeze and inhale at the same time. Continue to breathe in slowly and deeply for 3 to 5 seconds. Hold the breath for 5 to 10 seconds. Rest and repeat. DRO. Document, replace, observe. Here are the most common problems when using an inhaler. If a child drops off an inhaler on the first day of school and never touches it until next spring, then it will need to be shaken before use. A minute between puffs at minimum, or longer if direction indicate. This is especially important for student athletes. If the medication is not taken properly as prescribed, the medication will not effectively treat the symptoms and respiratory compromise may develop. Make certain that you know when the child should take his or her inhaler.
Inhaled medications are essential for preventing and treating asthma attacks, but the medicine is only effective when you use your inhaler correctly. Without proper use, your inhaler may not deliver enough medication to your lungs to control your symptoms. To properly use your inhaler, follow these simple steps. First, take off the cap of your inhaler and remove any lint or objects in the opening. Shake your inhaler for 2 to 5 seconds. Remember, if it has not been used for more than 48 hours, you must prime your inhaler. To prime your inhaler, depress the canister once. This ensures the next dose will deliver the correct amount of medication. Next, sit up straight or stand up. Breathe out all the way. Tilt your inhaler slightly and put it into your mouth with your lips sealed around the mouthpiece. As you begin to slowly breathe in, depress the canister. Remember, in order to deliver the medication into your lungs, it is important to start breathing in before depressing the canister. Continue to slowly breathe in over 3 to 5 seconds until your lungs are full. Hold your breath for 10 seconds, or as long as you can. If you need to take a second puff of your inhaler, wait 1 full minute between puffs. You should rinse your mouth out with water after using your controller or inhaled steroid inhaler. Be sure to spit out the water after you're done rinsing your mouth. Recap the inhaler for storage. And that's how you properly use an inhaler to treat or prevent asthma attacks.
Your responsibility in caring for a student with asthma is the following. Where will that inhaler be kept? Who will administer it? Will it be self-administered or assisted? And when is that inhaler to be used? It cannot be our determination if the medication is self-administered or assisted. Please review all forms provided by the parent or guardian. Allergic reaction is an immune response to a foreign substance and can result in inflammation and/or organ dysfunction. Allergic reactions may have many symptoms that could appear immediately or not for several days or weeks. Anaphylaxis is the most dangerous allergic reaction and can be life-threatening if not treated immediately. Signs and symptoms include a drop in blood pressure, so the student or coworker may become very weak or short of breath. The EpiPen is a prescribed medication that contains epinephrine to reverse the most dangerous effects of anaphylactic reaction. There is no need to remove the clothes, but avoid going through double seams of blue jeans. One of the hardest parts is recognizing what you see and reacting to it. Epinephrine can be self-administered if able to quickly reach the pen before becoming debilitated. The statute allows students to self-carry epinephrine pens. It is recommended that parents provide a second pen for the office. All teachers, staff, and coaches should know where the epinephrine is kept for each particular student. These locations should not change from semester to semester. But remember, epinephrine injectables are not interchangeable between students. Who is at risk for anaphylactic reactions? Students with asthma because they have lung involvement, and students with spina bifida because of latex allergies. Anaphylaxis is hard to predict, and the allergic response might progress and become life-threatening. These symptoms can include itching, hives, swelling of the throat and face, difficulty breathing, or just a sense of impending doom. If you see any two symptoms, you must react quickly. Many classrooms are designated peanut-free. This would be at the order of the physician and found in the allergic reaction packet, EpiPen packet. Peanut-free tables are also made available at each school if ordered by the physician. Please remember the peanut oils can best be removed with soap and water. Discuss this with your parents to ensure the child's safety. Signs can be placed outside the rooms to notify everyone that peanut tree nuts are not allowed in the room. Please include this information in your subfolder so that they do not eat in the room if they have peanut tree nut oils in their lunch. Again, know the location and check the expiration dates of all epinephrine pens monthly. Epinephrine is normally made by the body, and it will only increase the heart rate if given and it was not fully needed. If your student has an inhaler and an epinephrine pen and comes to you without being able to breathe, but also has the look of impending doom, skip that inhaler and give the epinephrine. It will reverse the anaphylaxis, but it will also work on relaxing the airway. The inhaler would only work on breathing and not reverse any allergic response. To administer an EpiPen, always seal your thumbs in a tight grip with the EpiPen. Never touch the orange tip, especially after the blue cap is removed. Hold in position for a count of 10 and give only in the thigh. Please watch the following video for EpiPen administration. This is what you will need to demonstrate when you come to the skills checkoff to complete your medication training.
This is the EpiPen auto-injector. It comes in two strengths. One that's for patients weighing 66 pounds or more. As you can see, it has a yellow label. And one for patients weighing 33 to 66 pounds. That's EpiPen Junior. It has a green label. Whether you have an EpiPen, EpiPen Junior, or both, it's important to remember to refill your EpiPen prescription before it expires. You can find the expiration date right here on the auto-injector. Also, take a look to make sure the solution inside the EpiPen is clear and not discolored. And since it's important for you to have two EpiPens on hand at all times, EpiPen and EpiPen Junior come in 2-packs. Each 2-pack also comes with a training device. Even if you carry an EpiPen everywhere you go, it can only help you if you know how to use it correctly. In a moment, I will show you how to self-administer an EpiPen. You can follow these steps whether you're administering EpiPen to yourself or are a caregiver administering EpiPen or EpiPen Junior. So to get started, begin by removing the EpiPen from the carrier tube by flipping open the cap and then tipping the tube and sliding it out. It's important that you don't place anything in the carrier because this may prevent you from removing the EpiPen when you need to use it. Once you're ready to use the EpiPen, start by grasping the unit with the orange tip pointing downward. The needle comes out of the orange tip, so make sure you never press, push, or put your fingers or hand over it. Next, form a fist around the EpiPen with the orange tip down, and with your other hand, pull off the blue safety release. To inject, hold the orange tip near your outer thigh. Then swing and firmly push against your outer thigh at a 90-degree angle until you hear the EpiPen click. The EpiPen is made to work through clothing. Continue to hold the EpiPen firmly against your thigh for approximately 10 seconds to deliver the medicine. Now that the injection is complete, remove the EpiPen and massage the injection site for 10 seconds. Most of the liquid will still be left in the EpiPen after you finish the injection. Once you've used the EpiPen, get emergency medical help right away. Then place the used EpiPen back in the carrying case. As you'll notice, the cap of the carrying case will not close after the EpiPen has been used. And lastly, make sure to take the used EpiPen with you to the hospital emergency room. To properly dispose of expired or used EpiPen units and carrier tubes, make sure to take them to your doctor's office or to a hospital. A used auto-injector with an extended needle cover will not fit in the carrier tube.
Auvi-Q is the same medication but different mechanism of injection. It is voice activated and will count only to 5 but at a slower pace. Hold in position until you hear the beep. Please watch the following video for Auvi-Q administration. This is what you will need to demonstrate when you come to the skills checkoff to complete your medication training.
Hey, I'm Ben. And this is Auvi-Q, the first and only epinephrine auto-injector with voice instructions for adults and children with severe life-threatening allergies. Did you get all that?
Good. Now, in case of an anaphylactic emergency, here's what you do.
First, pull Auvi-Q out of its case.
If you are ready to use, pull off red safety guard. If not ready to use, replace the outer case.
We're ready. Okay, red safety guard, give it a good pull.
To inject, place black end against outer thigh, then press firmly and hold in place for 5 seconds.
Auvi-Q should only be injected into the middle of the outer thigh. Also, feel free to leave your pants on. Auvi-Q will still work. However you know it's working, you'll hear a click, then a hiss. The needle will retract on its own.
But remember, do not remove Auvi-Q until the 5-second countdown is done.
5, 4, 3, 2, 1. Injection complete. Seek emergency medical attention. This device has been used and should be taken to your physician for proper disposal and a prescription refill.
Seek medical attention immediately afterwards and have a doctor check you out. And that's it.
The next slide will be a tutorial on how to administer the epinephrine pen. Please watch closely on how to safely cap the exposed contaminated needle.
Know your steps for successful injection. This video is intended to provide instruction on how to use the epinephrine injection USB auto-injector. The patient or caregiver should practice and watch this video carefully before using the epinephrine injection USB auto-injector. Injection USB auto-injector comes in 2 strengths. The auto-injector with an orange label is the 0.15 milligram and is for patients weighing 33 to 66 pounds. The auto-injector with a yellow label is the 0.3 milligram and is for patients weighing more than 66 pounds. It is best practice to check the auto-injector often. Look at the medicine in the epinephrine auto-injector through the viewing window regularly. If it looks cloudy, or has particles in it, or is discolored, or if the expiration date has passed, the epinephrine auto-injector should be replaced. Do not remove the blue caps until you're ready to use. When ready to inject, complete step 1. Remove epinephrine injection USB auto-injector from its protective case. Twist and pull apart the protective case to reveal the auto-injector. pull off both blue end caps. You will now see a red tip. The needle comes out of the red tip. To avoid accidental injection, never put your thumb, fingers, or hand over the red tip. Grasp the auto-injector in your fist with the red tip pointing downward. Step 2. Put the red tip against the middle of your outer thigh or upper leg at a 90-degree angle, perpendicular to the thigh. Press down hard and hold firmly against the thigh for approximately 10 seconds to deliver the medicine. Only inject into the middle of the outer thigh. Do not inject into any other part of the body. Remove epinephrine injection USB auto-injector from the thigh. Massage the area for 10 seconds. Check the red tip. The injection is complete and you have received the correct dose of the medicine if you see the needle sticking out of the red tip. It is normal for medicine to remain in the auto-injector after the dose is injected. If the needle is exposed, do not attempt to re-inject. If you do not see the needle, repeat step 2. Step 3. Get emergency medical help right away. You may need further medical attention. You may need to use a second epinephrine injection USB auto-injector if symptoms continue or recur. Step 4. Lay the black half of the carrying case cover down on a flat surface. Use only one hand to carefully slide the end of the auto-injector, needle first, into the black carrying case cover. After the needle is inside the black cover, push the colored half of the carrying case cover firmly over the non-needle end of the auto-injector. Take your used epinephrine injection USB auto-injector with you when you go to see a healthcare provider. Tell the healthcare provider that you have received an injection of epinephrine. Show the healthcare provider where you received the injection. Give your used epinephrine injection USB auto-injector to the healthcare provider for inspection and proper disposal. Ask for a refill if needed.
Anytime epinephrine is given, 911 must be called. That injection might only last 10 to 15 minutes, and maybe that is all the individual needs. However, they could need more and have a rebound reaction, and it could be worse than the initial event. If the child would initially show improvement, but then started showing symptoms of anaphylaxis again, and the emergency response team had not arrived, then you could give a second injection if there was another pen available at the school that was prescribed for this particular student. You inject into the other thigh. Never take another child's EpiPen to use. Epilepsy is a neurological disorder that causes seizures. There is a disruption in the electrical activity in the brain that causes loss of awareness, shaking, convulsions, or sensory experiences. Some may last a few seconds and can be missed, or others last a few minutes. They can take many different forms, but not all seizures result in loss of consciousness. The outward symptoms we see depend on where in the brain the disruptions are occurring. This is why it is so important to describe exactly what the student is doing during the event. Seizures alter movement, sensation, behavior, and awareness. Anything the brain knows to do can be stuck in a repeat mode. Generalized seizures mean the whole brain is affected, and we will discuss 4 different types: tonic-clonic, absence, atonic, and myoclonic. The first video is an example of tonic-clonic seizure, which is what most people think when they hear the word epilepsy. Getting a child to the floor is the safest location unless they are secured in a wheelchair. Please note what the arms are doing in comparison to the legs. Which way is the head turning? Always compare side to side, arms to leg. The next video will be of absence seizures. Since absence seizures can be so frequent, they can lead to struggling within the classroom. During each of these attacks, the child will miss a word here and another word there, and if you are teaching a building concept, the child will not be successful. In this absence video, you will see the child return quickly to normal activity and may appear to be daydreaming. There will not be any emergency response on this type of seizure, but to note the seizure and communicate that with the parent.
Seizures vary in type, but this is the kind most of us have seen. It's called a generalized tonic-clonic seizure, or grand mal. It's caused by a disturbance in the brain's normal electrical activity. First aid for seizures is simple. Protect from injury, especially to the head. Remove glasses or other potentially harmful objects. Turn on one side to prevent choking. Check for a medical ID. Don't put anything in the mouth. And don't hold down, because restraint could cause bone or muscle injury.
The likelihood that someone can die during a seizure is very small. And although the person may look as if they're going to die, that is that they oftentimes will become somewhat blue. There may be some changes in the breathing pattern. These are all part of the seizure itself, and they are all very temporary parts of the seizure.
Seizures usually end spontaneously after a minute or two, but afterwards the person may be sleepy, agitated, or confused. A seizure can occur at any age, from the very old to the very young. An ambulance should be called for a first-time seizure, when someone is injured, pregnant, has diabetes, or when seizures are prolonged or occur one after the other.
This girl has absence seizures, and you will see her have one while she's talking.
Because he can be as heavy as ever.
And there's a real blankness, a vacant look in the eye, and then all of a sudden they're right back with you and able to engage.
Oh, pardon?
Sorry? Absence seizures can be mistaken for daydreaming. One of the hallmarks of absence is that the seizures happen many times in a day. Sometimes they're so fleeting, they're easy to miss. This boy is having frequent but very brief episodes. You can see his eyes flutter up. He's out of touch. Then he becomes fully aware again.
Myoclonic is a rapid, brief contraction of body muscles, usually occurring at the same time or both sides of the body. A tonic or drop attack is abrupt loss of muscle tone. The next video is an example of drop attack. See how the body frame totally gives away. Again, no first aid with the seizure, but the child does require constant intervention to prevent harm. These children should never be on heights of any kind. Partial seizures affect only one side of the brain. Simple partial seizures are the one type of seizure where the student remains conscious and they experience a sensory phenomenon. Complex partial is what we have mostly in the school district, and you will see random activity and the student will be out of touch with the environment, much shorter in duration than the grand mal. When a person is having a partial seizure, it is important that the person is kept safe during the seizure. Use your body as a shield from steps, outdoors, and traffic. Avoid grabbing someone in a partial seizure as they might start swinging. The first video you will see is an example of partial seizures that is up and walking. You can see how a layperson or a police officer might see this as being belligerent and not following orders. The second video is a great example of repetitive motions. No first aid is required for partial seizures, but stay with the student until full awareness resumes. Always with every type of seizure, document and time the event.
You can see in looking at the chart, we're looking at least a 10% increase from our first quarter to our second.
Adam? You're okay, Adam. You're fine, you're okay.
What's going on?
He's having a seizure. It'll pass. He's okay. You're okay.
Do you need help? Do you need me to call 911?
No, it's not an emergency. You're okay, Adam. You're okay. Do you mind pushing back the chair, please? Thank you. You're fine.
It happened again?
He just had a seizure.
You gotta sit down for a minute. Guys, this happens to me sometimes. I have epilepsy. This happens to me sometimes. Just bear with me for a couple of minutes.
Okay, sounds dangerous. It is dangerous. It can't be any more dangerous than that shutter. This was a very powerful gun. I love it because of the historical connection to the West.
You alright?
37,000. In a few years, I'm going to have to sell my entire collection. Might as well start now. This is cool. Where did you get it? I bought the rifle from a friend I knew in Wyoming, and he said, "You guys see something like this once in your life? It's for hunting buffalo. It's a 44-90 caliber. And this was the most powerful caliber made in 1874. Yeah, it was a powerful enough bullet that 800 yards away, you could still bring down a buffalo. Yep. Buffalo hunting was a big business. This rifle would pack one hell of a punch and was the top choice for big game in North America.
You want something to wipe off with?
1974, this rifle took the Creedmoor record, hitting 19 out of 20 targets at 800 yards. Well, yeah, this is where the term sharpshooter came from. It wasn't from a sharp's rifle. Originally, the guys could shoot really far.
Some people know when they're going to experience a seizure. This would be called an aura. They may see or hear things before the event takes place. Some other consideration of seizure activity is to have a plan in place to provide privacy in case the student loses bowel or bladder control. Some use a beach towel that can be used for a drape. The child will also need a place to recover as they come out of the seizure. Not everyone that has seizure has epilepsy. How the child wakes up can tell the primary care provider a lot of information. Make sure to include that in your documentation. These situations would constitute an emergency and the need for an emergency personnel to be called. A child with a history of seizures and the event has lasted longer than 5 minutes. A child keeps going in and out of a seizure without consciousness regained. A child that was injured or has diabetes. First time event for this child. Any breathing difficulties, or for any seizure that took place in water. Many students have epilepsy or are well controlled on medication to prevent seizures. Airway patency and safety are a priority to the student. If the student does not experience a seizure, assist the child to the floor, if able, and then turn them on their side. Make a safe environment by moving furniture away to prevent injury. Students with a history of seizures should have a seizure action plan that informs the school personnel what the student's licensed healthcare provider has prescribed to treat the seizures, which may include Diastect rectal gel. While staying with the child during a seizure activity, observe and compare the body. Look at what the arms are doing. Which way is the head turning? What is the mouth doing? What is the left side doing compared to the right side? These are all important to the physician and can help locate where in the brain the seizure activity is occurring. Always time the seizure. Never restrain or place anything in the mouth. They may bite their tongue but may not swallow it. Breathing will become shallow. Always make sure nothing is tight around the neck. For a diabetic that's unresponsive, we rush to give glucagon. For an allergic reaction that progresses to anaphylaxis, we rush to give epinephrine. For a known history of seizures, we wait before giving Diastat. Usually the physician will order 3 to 5 minutes following the start of a seizure. Waiting gives the opportunity for the seizure activity to stop on its own before administering the sedative. It would be best practice to keep the child inside the wheelchair when the seizure starts to prevent harm to you or the student. However, as with any seizure first aid, make the environment safe to prevent secondary injury. Pad the wheelchair with something soft to protect and support the head. When receiving Diastat, the green ready label must be in view for us to keep the medication at school. If you don't see the green ready label, it means the medication in your Diastat syringe is not properly locked in and could lead to overdose. Send it home with the parents to have it fixed. Steps to administer Diastat. This will be part of your skills checkoff. Number 6 is the recommended position when working with the student in need of Diastat. Student facing you and the top leg drawn in. Insert the syringe into the rectum, followed by 3 steps of 3. 1. Slowly push the plunger down over a count of 3 until it stops. 2. Hold the syringe in place for a count of 3. 3. Remove the syringe, hold the buttocks together for the count of 3. Please watch the following video for Diastat administration. This is what you will need to demonstrate when you come to the skills checkoff to complete your training.
Let's review. First, remove the protective cover. Then lubricate the tip with lubricating jelly. Turn the patient on the side facing you. Bend the upper leg forward, exposing the rectum. Separate the buttocks to expose the rectum. Gently insert the syringe tip into the rectum, and then count out loud, slowly. 1, 2, 3, while pushing the plunger in. Count again. 1, 2, 3, before removing the syringe. And finally, count 1, 2, 3, one last time while holding the buttocks together. After administration, and depending upon your prescription, there may be some unused medication left over. Remember, this prescription was for 15 milligrams that was dialed and locked from a 20 milligram Diastat AccuDial diazepam rectal gel delivery system. That means that 5 milligrams will have to be disposed of. All you do is pull on the plunger until it is completely removed from the Diastat AccuDial. Point it over a sink or toilet. Replace the plunger and push until it stops. Then just flush the toilet or rinse the sink until all of the gel is gone. As for the delivery system itself, just throw it and all other used materials in the trash and away from children, just as you normally would.
Diastat is Valium, which is a heavy sedative. Plus, the child just had a prolonged seizure, so breathing may become shallow. Know who is in your building that is CPR certified. Turn the student on their side and monitor while waiting for EMS to arrive. Modular 4. The majority of our policies were addressed in the other modules. Please make yourself aware of 09.2241 AP.1 and contact health services for any questions. Thank you for your time and willingness to assist health services and the needs of the Bullitt County students. To complete your training, you will now take the open book exam. Once you have passed that test, print out your certificate and you will register for the skills competency and checkoff to be held at the Board of Education. Details and times to register can be found on the health services page or contacting one of the nurses.